introduction. Can everyone hear me okay? Great. Good. So again, I just wanted to thank ALSChem for the kind invitation to have me come and present. It's always a pleasure. I was at the last two meetings, last one in Germany and in England, and it was really a delight to be here with such great researchers. Met many of you in the past, and it's great to chat and to listen to your wonderful research. So I'm going to talk today about creatine in neuromuscular disorders. I'm not going to rehash a lot of the stuff that we've done, so I'm going to skip over a few of the things and try and focus on some of the stuff that we're doing more recently, and some of it just was actually data crunched last week. So disclosures, I won't go through all of them. The most important is that I'm the founder and CEO of Creatine Corporation and Stay Above Nutrition, and we do have multi-ingredient supplements. Some contain creatine. The creatine in all of our studies and in our supplements is CreaPure. So from a disclosure perspective, since they partially supported my transport here, just wanted to disclose all of that. So I'm a neurologist, and I'm very interested in everything from the brain down to the muscle, but my main area of specialty is neurometabolic disorders and neuromuscular disorders. Now, there's a lot of interest in creatine in the brain, and I won't go through all of that. There's many studies that have shown in the preclinical models a significant benefit in things like Parkinson's disease, Huntington's, stroke, hypoxic ischemic encephalopathy. And we heard a lovely talk earlier today about the potential use of creatine in moms who have children who are at risk for cerebral palsy / hypoxic ischemic encephalopathy. I could talk about that for the whole time, but I won't. Very interesting stuff. Next, in neurology, we think about disorders of the spinal cord. One of the disorders I see a lot is called hereditary spastic paraparesis, which is a genetic disorder. Many of them have mitochondrial dysfunction, oxidative stress as final common pathways, and you'll see why that's important in my talk. And certainly this is something that we put our patients on, creatine and other mitochondrial enhancers. There's definitely been a lot of work, and Rod Snow, whom some of you are familiar with, did a sabbatical with me, and we did some studies looking at the use of creatine in an ALS mouse model, and we compared it to riluzole. Riluzole is the current FDA-approved drug for ALS. Cost is tens of thousands of dollars per year, and the creatine was equivalent. Part of the reasons, however, I think why creatine failed in clinical trials is by the time we diagnose someone with ALS, they've already lost 70 to 80% of their neurons, so there's not a lot left. So where I see it being potentially beneficial is the 15% of our patients who have genetic mutations like the G93A mutation, and if we can get them before they start losing nerves, an ounce of prevention is worth more than a pound to cure. And the same holds true for a disorder that we see a lot, spinal muscular atrophy. Treating these kids when we do newborn screening and we treat them within the first 2 weeks with gene therapy, it's effectively curative. If you wait till they're even 2 or 3 months of age, there's almost no benefit whatsoever. So it's a really good example where an ounce of prevention is worth more than a pound to cure. And I think the same is true, and even more so for optimal nutrition and different supplementation. Now, there have been a few publications on myasthenia gravis. I reviewed a paper, I think, years and years ago where a person who had myasthenia gravis was on creatine and showed benefits. Part of the reason why I think myasthenia gravis is a group of patients who might show benefit is that the treatment of choice is corticosteroids. And as you'll see, corticosteroids are something where creatine could have potential benefit, and I'll show you one of our papers in that regard. The same is true of muscle disorders. I won't talk about the inflammatory myopathies, but I do think that this is something where creatine is to be of significant benefit. There have been studies in dermatomyositis, but indeed all of our patients, and we're going to hear shortly about statin-induced myopathies, one of them is actually an antibody-mediated disease, and we treat our patients with prednisone and methotrexate. And what you'll see in a minute, too, is that we found that there's deficiency in these patients in their muscle. So treating a deficiency makes a lot more sense than supercompensating someone in a sufficient state. What I'm going to focus on today is Pompe disease, mitochondrial disease, and muscular dystrophies. So we've seen and we know very much about aging, and we heard a nice talk yesterday about from Dr. Kando about aging, but we see the same thing in our patients. It's just to an accelerated or more rapid process, and that is muscle atrophy, muscle weakness, and atrophy often is associated with weakness, bone loss, because if you're hypodynamic and you don't move very much, you don't get the piezoelectric effect on bone. If you're weak, there's a higher fall risk, which if you are osteopenic, increased risk of hip and compression fractures, a loss of independence, which leads to institutionalization. And something I'm going to talk a little bit more about is obesity with low muscle mass, sometimes called sarcopenia in the aging literature. So one of the things that is quite clear is that human aging. So if you might be bored and you think, well, I don't care about neuromuscular disorders, everyone in this room has a mitochondrial disease and a neuromuscular disorder, and that is human aging. And if you look at any of these disorders, these are some of the muscular dystrophies that we see, there is evidence of mitochondrial dysfunction. And I think mitochondrial dysfunction is really at the heart of a lot of the things that we do see. If mitochondria don't work properly, we activate the inflammasome. We need mitochondria and energy to support protein synthesis. Oxidative stress goes up when there's mitochondrial dysfunction, and it can lead to stem cell exhaustion in the brain, satellite cell in muscle. I'm going to focus today on how nutrition can impact this process and secondarily these processes here. So how do we treat our myopathies? Well, there's a whole bunch of things that we do. Low-hanging fruit, identify and treat deficiencies. One of the most common deficiency that we get in Canada is vitamin D insufficiency. And in fact, when we checked our many thousands of patients, we found that 13% were in the rickets range. So if you're already set up for muscle weakness and you're set up for osteopenia, the last thing you want is to have rickets. And we've had actually patients referred for high CK and muscle weakness, as is this a mitochondrial disease, and all they had was non-detectable vitamin D. So again, treating deficiencies is important. We know if you have low muscle mass, you're at increased risk for type 2 diabetes, and that's very, very common in our patients because the largest site of glucose disposal is skeletal muscle mass. Exercise is very well shown in multiple studies, including our own, to improve muscle function in patients with muscular dystrophy. And I'll show at the end how we're combining this with nutrition. Use of gait-assisted devices. I put this up because essentially when people become more weak, they need a cane, they need a walker, and eventually into a wheelchair. And those have major impacts on people's independence, major impacts on their ability to make money. And what we found is that the need for each of these assistive devices is proportionate to the loss of muscle strength. And there's a threshold below which you have an increased need for these devices. So keeping people above a threshold with nutrition and exercise is important and has significant long-term benefits. We do a sleep study on all of our patients. It's very well described that if we don't get stage 3 and stage 4 sleep through circadian rhythm and clock genes, we downregulate mitochondria, and that's important. Adequate protein. I'm going to talk more about this. For most of our patients, we're recommending greater than 1.2 grams of protein per kilogram per day, but I emphasize that quality is important, and you'll see what I mean by that when I show you some of our data. Creatine monohydrate, we recommend this to all of our patients based on the studies I'm going to show you. So the muscular dystrophies, there's many that we see in the clinic. Some of the more common ones that we see is Becker and Duchenne muscular dystrophy, myotonic dystrophy type 1, and Pompe disease. And those are the three that I'm going to just highlight here today. So the reason I got into this area, and I think my first paper in the area of creatine metabolism, was my concept of treating deficiencies makes more sense than supercompensating sufficiencies. So Johnny Parisi, he was an undergraduate student, he's now Dean of Science. He was my first undergrad student. We did this study where we looked at muscle biopsies that we had in our biobank, and what we found was low total and phosphocreatine content in mitochondrial disease, muscular dystrophy, and inflammatory muscle disorders. Now, this has been replicated by many people using MR spectroscopy, and in the brain as well for mitochondrial disease, we see also lower creatine and, phosphocreatine. So why might creatine be of benefit in muscular dystrophy? Well, there was strong evidence when we started this in the early 2000s that creatine can increase fat-free mass, it can increase strength and power. There's data it can be a direct or indirect antioxidant. There is some data in the MDX mouse that it could improve mitochondrial function. And in the MDX mouse, which is a model of Duchenne dystrophy, there is also lower calcium. So high calcium levels is part of what is deleterious to the muscle, and that was reduced in the MDX mice. So knowing that these processes are important to our kids with Duchenne dystrophy, we set out to do some studies in the area. At the time, there were 2 papers that had come out looking at Duchenne dystrophy. So just very briefly, Duchenne dystrophy is the most common muscular dystrophy. It's about 1 in 4,000 live male births. And why it's devastating for these individuals is they start getting weak just as they're going into grade 1, but by age 10 without treatment, about 50% are in a wheelchair. With corticosteroids, which I'll talk about in a minute, you get about a 2-year extension before you end up in a wheelchair. The CK is in the many tens of thousands. And in fact, very early on, before we knew what the gene was, people thought this was a creatine disorder because the CK was so high. As I mentioned, wheelchair invariably by their teenage years, and most folks are dying in their 20s. But even without a definitive cure, we're now having people who traditionally were only living to age 25, living to age 35 on average. And Becker muscular dystrophy is essentially the same as Duchenne. It's just you have a partial dystrophin protein versus a complete absence in Duchenne, and that's why it's more severe. So how do we treat these patients? Well, there's secondary inflammation. So folks said, well, if there's inflammation, let's treat them with prednisone. So with prednisone, keep in mind this number. The attenuation of the loss of strength is only 4%. So there's only about a 4% benefit with prednisone. But prednisone is probably the most toxic drug in the world. It has a plethora of side effects. Increase in fat mass. Some of our patients go from 8% body fat to 60% body fat in 1 year when we start them on steroids. Everyone knows it's just so well described. There's a reduction in bone mass. Osteoporosis and osteopenia are common. Increase in cataracts and growth suppression. So our kids who are on steroids are very, very stunted in their growth. Linear growth is attenuated with corticosteroids. And many of the families, because of the real side effects or perceived side effects, don't take the medication, even though it does prolong their ambulatory capacity. In a recent paper we haven't published yet, it also helps to protect the heart and breathing capacity. Keep in mind, it is the only FDA-approved drug for Duchenne muscular dystrophy. All these side effects for a 4% bump in power. So what about corticosteroids? One of the things and part of the reason why we were interested in using creatine in boys with Duchenne dystrophy is knowing that they're on steroids could be attenuate some of the deleterious effects. So we did a study with Brian Roy with 4 groups of Sprague-Dawley mice. We used prednisone, 7 mg per kilogram, which is actually a fairly low dose of prednisone in a mouse because they have a more rapid turnover. And then we had creatine on its own or creatine to see if we could attenuate the deleterious effects of prednisone. Treated them for 2 months, and I'll just show you the bottom line here. Number 1, with the corticosteroids, there was a reduction in bone mineral content, but you can see here with creatine or with prednisone and creatine, we could attenuate that drop. So even in the face of this very toxic drug, we could actually preserve and in fact increase bone mass. The other thing that corticosteroids do is it's a bit of a double-edged sword. You can get a corticosteroid-induced myopathy because it can lead to type 2 muscle fiber atrophy. So what we found is that this is the area of the type 2 fibers here. In prednisone, it was lower, but that was actually higher or maintained to normal when they had creatine and creatine plus prednisone. The second thing, of course, is we could load the muscle. So we could both load muscle and we could attenuate the type 2 fiber atrophy. We also attenuated the linear growth restriction. So this is the growth curve over time, and you can see that the mice on steroids were falling off the growth curve, just like we see in our kids, but we completely protected them when we had creatine on board. So what about clinical trials? This was one of the first studies that came out in 2003. 15 children with Duchenne and Becker muscular dystrophy. It was an RCT, double-blinded, 12 weeks of intervention. Creatine was fairly low, only 3 grams per day. And we've heard that perhaps this is too low and we should be going for higher, and that's why we usually say 100 mg per kg, which is usually around the 7 grams in an adult. And they looked at muscle strength, they looked at contractures, they used MR spectroscopy to look at phosphocreatine, bone mineral density, and this one here I'll highlight. They looked at N-tylopeptides, which is a marker of bone breakdown. Now what they reported, which was no surprise, increased strength and endurance. There was less contracture development over time, improvement in bone mineral density. Little surprising over such a short period of time, and I said, well, I don't know if I really believe that. And decrease in N-tylopeptides, it was quite dramatic. It went down almost 50%. I said, geez, that's crazy. But I saw this when we were doing our study, and you'll see we subsequently measured it as a consequence. So Maggie Walter, who's actually from Munich, also published this lovely paper, one of the first papers ever using creatine in neuromuscular disorders. And they had a mixed population, some FSH dystrophy, some Becker's. It was a randomized crossover trial. double-blinded, 8 weeks of intervention, 8 weeks of placebo. They did 10 grams in the adults, which is similar to my 100 mg per kg, and 5 grams in the children. The MRC sum score, which is essentially you just check from 0 to 5, you grade the strength, add it up for a number of muscles, was greater when they were on creatine, and the neuromuscular symptom score was better when they were on creatine. So that was Maggie's study. So based on that, we received some funding to do this study that was 30 boys with Duchenne muscular dystrophy, randomized double-blind study. So everyone was on the drug or placebo. We didn't know. There was a washout period in between, and we tested them before and after each of the interventions. Again, 100 mg per kg. 50% of our boys were on corticosteroids, 50% were not, which reflects what we see in the clinic. About half the families choose not to go on them. And we measured all of these outcomes. You can see here I have N-telopeptides. I threw that in at the last minute when I saw that other data, saying, oh, I don't believe it, there's no way. So what we found is the mega score, again, when you add up your MRC grades, was like it always goes down. So it went down less when they were on the creatine. Hand grip strength in the dominant hand went up significantly. The non-dominant hand didn't change. And that, I think, reflects what I think most of us believe, and that is that there's an interactive beneficial effect between exercise and dietary supplements, including creatine. We actually found lower N-telopeptides, which was interesting. Looks like there's indeed some potential benefit to decrease breakdown. So this is a marker of breakdown. So by decreasing breakdown, you get a net increase in synthesis. And the important thing is that we found that it was additive to corticosteroids. So you're already getting the benefits of corticosteroids, probably in the long term, less deleterious effects of the corticosteroids, but the increase that we saw was the same for both groups. We went on to do a study in myotonic muscular dystrophy type 1, which is a very common disorder, especially due to a founder effect in Canada. It's about 1 in 8,000 individuals. It's what's called a trinucleotide disorder. So all of us have trinucleotides in the intronic region of our gene. Hopefully none of you have trinucleotide expansions over 50 in your DMPK kinase gene. But if you do, you will start to get manifestations of myotonic muscular dystrophy, which is a multisystemic disorder. It affects the splicing of the mRNA, anything from cognitive impairment, cataracts, orofacial weakness, distal progressing to proximal weakness, cardiac conduction block, a very devastating disorder, especially when the repeat expansion is large. We get the infantile form, which is fatal usually by age 20. So we did a randomized crossover study, very similar to what I showed you before in these folks, but we showed absolutely nothing. Part of the reason I think why we didn't show anything is that it's a spliceopathy, and the spliceopathy actually affects the creatine transporter. So I think that we just weren't getting transport into the muscle in these folks, number one. Number two, as you'll see, I'm a big fan of multi-ingredient supplements to target the final common pathways, which we'll get to in just a minute. However, again, if you take all of the studies that were published and put them into what's called a Cochrane review, we published this a few years ago, and on average, it's about an 8% increase across all of the studies. We found that, and that's about what they found. It was 8.5 across all of the different studies. Increase in phosphocreatine has been reported in some. We didn't see it in the myotonic patients, which again I think might be the spliceopathy affecting creatine transport in those patients. The meta-analysis, it's actually, the numbers are much higher now, but they're still coming out about the same, about an 8.5 increase in strength and just over a pound increase in fat-free mass. Now I presented this years and years ago at the American Academy of Neurology, and everyone's going, oh, 8.5%. And Birch Griggs, who was the first person to do a study in prednisone, got up and said, I'll remind people that the increase with corticosteroids is 4 to 6%. So small changes over a long period of time can have significant functional benefit. And think about it. Side effects, prednisone versus creatine? Give me a break. All right, so one of the concepts that I also put forth at about the same time, the Flint Beal, the late Flint Beal, great neurologist, I was fortunate to publish this review paper, or hypothesis really, and that was that for us to treat neurologic disorders, we can't just target one pathway. There's multiple final common pathways of dysfunction that we see in nerves and muscle, which includes oxidative stress, apoptosis, inflammation, mitochondrial dysfunction. And to get the best bang for your buck, my hypothesis was that we should target them. Now we know from ALL, that's acute lymphoblastic leukemia, that the huge improvements in efficacy came when we started to use multiple chemotherapeutic agents. So we did a study with Eric Payne, who's now a neurologist, where we looked at the MDX mice. And what we did was we tried to target the multiple final common pathways in Duchenne muscular dystrophy. And we've applied that since to mitochondrial disease, which I'll talk about. I won't get into our aging work. We've done a lot there, and muscular dystrophy. So this is a complicated slide, but it does make sense. What we did is we had the MDX mouse model of Duchenne muscular dystrophy, and we gave them a variety of different interventions. Beta-hydroxymethylbutyric acid, which has been shown to lower CK, and it actually did that. Creatine monohydrate, I'll highlight because that's obviously what everyone's interested in. Alpha-lipoic acid, a potent mitochondrially located antioxidant. Conjugated linoleic acid, to reduce body fat. It's one of the more effective nutraceuticals to reduce body fat. And when they're on steroids, we get an increase in fat. So we thought maybe that would work. And sure enough, it did. Didn't do much else. Prednisone, combination of all of them, which was our hypothesis that it would work better than either one in isolation. And the combination plus the standard of care, which is prednisone. So what did we do? We have grip strength, fatigue, rotorod, CK activity, fat pad, creatine content in internal myonuclei. Internal myonuclei, the more you get, that means the muscle is damaged and is trying to repair itself. So what these are is the rank. So a 1 is good, a 7 is bad. So we ranked each one of these. And so if you add up the total, the lower number is better. And what you can see here is prednisone, the only FDA-approved drug. Combination of nutraceuticals was significantly better. Combination plus standard of care was the best score by far. So again, I think highlighting that creatine we know in clinical trials is beneficial, but targeting multiple final common pathways with creatine in the mix was definitely better than prednisone, but when we added all of them together, it was synergistic. So I'll turn to mitochondrial disease, where we applied this multi-ingredient supplement concept. So mitochondrial disorders is my main area of clinical specialty. These are genetic disorders that affect the electron transport chain. I won't get into this, but these numbers that you see in mitochondrial disease reflects the point mutation in the mitochondrial DNA, and this results in neurologic disease, which is why I see these people. So we see seizures, developmental regression in kids, optic atrophy, visual loss. There's a horrible disorder called Leber's, where they get sudden, painless visual loss, completely blind in their late teenage years. It's a horrible disorder. You can imagine going blind when you're a teenager, going out and partying and everything. And it's often triggered by smoking. So they go to parties, smoke, and poof, they go blind overnight. Anyhow, there's a variety of disorders. There's over 200 point mutations in the mitochondrial DNA. Everyone in this room got your mitochondrial DNA from your mummies. Your dads all died in the sperm. And so because of that, we can actually trace back human evolution. So if I sequence the mitochondrial genome between any two of you and look at the different, what we call haplogroup, I can tell when you had a common mom. All of us had a common mom 220,000 years ago in sort of north part of South Africa. And Doug Wallace used mitochondrial DNA to trace the out of Africa hypothesis. Anyhow, let's get back to disease. Next slide. I don't know, it's not advancing. There we go. So what are the manifestations? As I mentioned before, as neurologists, we tend to see these things with seizures, encephalopathy, droopy eyelids, eyes that don't move, blindness, hearing loss. Many of these are similar to human aging. So high-frequency sensory neural hearing loss. Any of us who are over 60, you don't hear those high pitches anymore. Cardiomyopathy, constipation, abdominal pain. But what most of us in the room are interested in is weakness and or exercise intolerance, because the mitochondria, as you know, your VO2 max is critical to performing endurance exercise. I think you're going to have to advance it. I don't know if the battery's dead. Thanks. So how do we treat these patients? So traditionally, people have said, well, what are the consequences of mitochondrial dysfunction, and how are we going to treat them with nutritional supplements? So if the mitochondria don't work properly, we create reactive oxygen species, especially at complex 1 and complex 3. So naturally, antioxidants was one of the core therapies that people were using. Also, if we cannot flux to generate ATP aerobically, what does the body do? You flux through glycolysis and make lactate, and you crank through phosphocreatine. And that's probably the reason why the brains have low phosphocreatine and patients fatigue extremely rapidly. So their activities of daily living are severely compromised. In fact, in our patients with MELAS syndrome, the average VO2 max, which I think will resonate with folks here, 8 mils per kilogram per minute. And they estimate for independent living in older adults, you have to have a VO2 of 12 mils per kilogram. So you can see how compromised these patients are. Next slide, thanks. So there have been a number of clinical trials. Most of them were very, very small, open label stuff, no double-blind crossover stuff. The problem as well, too, is the outcome variables. Giving an antioxidant for a few weeks and thinking you're going to change VO2 max or strength is kind of decerebrate. It just, people aren't thinking, and so they say it doesn't work, but they're not using the right outcomes, nor were they studying them for long enough. The other thing I noted is many of the cocktails that they were coming up with, we call it the mitochondrial cocktail, were just redundant antioxidants targeting the same pathway instead of targeting multiple final common pathways. So again, as I mentioned before, I put forward the hypothesis that targeting the 3 final common pathways that increased ROS, decrease in your alternative energy sources, and the only one we can do something about is phosphocreatines. That's why we started with that. And then improving electron transport chain flux. So we did a study. This was higher intensity activity. So, when you're going up a flight of stairs, doing some brief activity in patients with mitochondrial disease. It was the first randomized double-blind crossover study. We used 10 grams loading and then 4 grams for a week. And we looked at repetitive hand grip activity, because, pushing, pulling, using your arms, and dorsiflexion activity where we could get very reproducible measures. So this is over 60 seconds of on 9 seconds, off for 1 second, and you get this fatigue curve. And what we found is that when they were on creatine, even in the first 10 seconds, there was better power output. And it averaged about 11% improvement for both the hand grip and the dorsiflexion. But, of course, short-term study, we did not see a change in VO2 max. Next slide, please. So turning to the multi-ingredient supplement approach, we then did the first multi-ingredient supplement crossover study that was double-blind. We had 2 months on a drug or placebo, 2-month washout, and crossover to the alternative. We used coenzyme Q10, vitamin E to be a membrane antioxidant, creatine monohydrate, and alpha-lipoic acid. The alpha-lipoic acid forms a redox couple in the mitochondria with the coenzyme Q10, and that's why we chose this. We use this, and I'll use this term later, that's my mitochondrial core concept. We had 16 patients with genetically confirmed mitochondrial disease, and what we showed was lactate was lower. We used markers of oxidative stress, 8-isoprostanes were lower. We also showed that the CoQ10 we used was bioavailable, which is important in a lot of our studies too with creatine. We show that it gets in the muscle in our aging studies and such. And also a second marker of oxidative stress, this is DNA damage, 8-hydroxy-2-deoxyguanosine was lower. Next slide, please. However, as is usually the case, I was criticized and people said, oh, Mark, you got 4 ingredients, which one is working? And I said, I don't give a crap what's working. It's designed, you dummies, did you not read my paper, that we're targeting the final common pathways? But everyone is so indoctrinated into big pharma for 50 years and continues today. Identify the target, find one drug that engages the target, do the PK, do your phase 1, your phase 2, never ever use more than one drug. It's not going to help our patients. It's not going to help aging. But I listened to them, used my clinical overage money out of my own darn pocket. Don't know why I did it, but I did, just to prove them wrong. So we used one agent. So we did the exact same thing, but we used just CoQ10, because I go to UMDF meetings. Oh, Mark, it's the CoQ10 that's working. No, dummy, it's everything. But anyhow, we used huge doses of CoQ10, 30 genetically confirmed patients, and I paid for MR spectroscopy in the brain. We did cycloergometry, the whole 9 yards. Did it work? Next slide, please. No. All this nice stuff we showed before, we didn't see anything. No reduction in lactate, no reduction in oxidative stress. I mean, there was a tiny increase in cycloergometry, very, very minimal, wasn't quite stat significant, and a little decrease in choline compounds, but no changes in creatine in the brain. Next slide, please. So I'll turn to Pompe disease here. Pompe disease is a genetic disorder with a mutation, what's called the GAA gene. And what its job is, in the lysosome, it breaks down glycogen. So what happens is that if you don't have this gene, your lysosomes fill up with glycogen, and eventually you can see here the difference between the purple and the pink. The pink is sugar, and the purple here is skeletal muscle. You displace skeletal muscle as you gradually accumulate these big balls of lysosomes full of sugar. It leads to progressive weakness and hypotonia in the kids. a function of how much residual enzyme activity. If it's less than 2, you have profound disorder in children with cardiomyopathy. If you have 10 or 15%, you'll get weakness in adolescence, but eventually it progresses to the need for respiratory support. So it's a pretty severe disorder. And how do you treat it? Well, there's a drug that's been produced, it's been around for about 20 years from Genzyme, called enzyme replacement therapy. So essentially you make the protein, you infuse it into the blood, and the mannose-6-phosphate receptor grabs it, pulls it in, and that does show some benefits, which I'll show you in a minute. Substrate reduction therapy, that means you have less glycogen over a long period of time. If there's less glycogen through autophagy, you can have less inside the lysosomes. That's what SRT is, and that's why some people think that a ketogenic diet would be helpful. Chaperone stabilize the enzyme. There's a new product from Amicus which combines the two, which was about equivalent to the new generation ERTs. Gene therapy, I won't talk about that, that's not here yet. Increasing the uptake, which is probably one of the ways that exercise works. Autophagy. Autophagy is, you need lysosomes, of course. And if you impair autophagy, you don't quality control muscle. So you start to accumulate all sorts of proteins which are dysfunctional. And this, Nina Rabin, who's one of the top researchers in the world, feels that it's this impairment of autophagy, which is really limiting the full potential of treating these individuals with ERT. A recent study came out from an Italian group using antioxidants, showing benefits. And then I'll show you later, all of our patients, unfortunately, have obesity. Next slide, please. So this is the fundamental study, and I'm just going to show you big pharma approach. One target, one molecule, spend billions or millions of dollars and make billions of dollars. So the primary endpoint in this, they had 90 adult patients, 6-minute walk test. I'll show you that data. The drug's called Myozyme. So you infuse it, gets taken up into the muscle, and it helps to alleviate symptoms. Next slide. So this is what we pay $1 million per patient per year for this 28-meter improvement. So based on that, the FDA approved it. It's approved in Germany. It's approved all across Europe. It's approved in Canada for 28 meters improvement in their walking capacity. Oh, there we go. So we did a study, again, using the multi-ingredient supplement approach to see whether we could actually enhance the benefits of enzyme replacement therapy through a fairly inexpensive multi-ingredient supplement that targeted the final common pathways. So what we wanted to do was to see if we could activate autophagy, enhance mitochondrial function, and of course we had creatine monohydrate. The other thing we wanted to look at was the ketogenic diet as a substrate reduction therapy. Was that of any benefit? Because all the patients think that it's great. So what we did is we used the GA knockout mouse. This is Nina Rabin's mouse model of Pompe disease. And we had a number of treatments. We used the standard ERT, and keep in mind, every group got the same dose of ERT. But we used something called 1,3-butanediol, which is a ketogenic precursor. We used the ketogenic diet. We used our mito-antioxidant, which had beetroot, creatine, CoQ10, alpha-lipoic acid, and vitamin E. Again, my mitochondrial core concept. And for reasons I don't have time to get into, we also added citrulline and beta-hydroxymethylbutyrate. And then we tried everything together. So what did we find? So this is a galectin-3 is a marker of impairment in autophagy. These are the wild-type animals. These are the GA mice. You can see this big impairment of autophagy. ERT, so this is the standard of care, does not improve autophagy. And Nina and others have said, we have to also improve autophagy. And you can see here our mitochondrial enhancer was better than just ERT. Keep in mind, everyone here is on ERT, but the best is when you combine them all. And that was a ketogenic precursor plus our mitochondrial enhancer. Again, I mentioned before, an Italian group showed benefits from antioxidants, lowering oxidative stress and improving function. Again, you can see higher oxidative stress in the mutant animals. Does not come down with ERT, but we could bring it down with the multi-ingredient supplement, but the best was the multi-ingredient supplement with the ketogenic precursor. But ketogenic diet, interestingly, did absolutely nothing. Next slide. More importantly, what we found is that these metrics we were measuring, oxidative stress and impaired autophagy, correlated with function. So if you lowered oxidative stress, if you lowered the autophagic impairment, you had an improvement in function. So I'll turn back to some human work, and I'll finish with this. This is obesity with low muscle mass, aka sarcopenic obesity. And what's interesting is that we found in our patients that if you looked at them, people would go, oh, they're really thin. There's no problem with obesity. They look so thin. But it's hidden. And the issue is they have low muscle mass, and so it's hard to identify that they actually have increased body fat. The problem is that we use BMI, especially clinicians do, as your marker of obesity. So BMI, as you know, of 30 is anything over that's considered obese. But in our clinic, we have a DEXA scanner, so every patient gets DEXA scanned. And what we found is that when we DEXA scan patients, everything here in this box is sarcopenic obesity. And that is that these patients were obese, but BMI was saying they're normal. So their family doctor said, don't worry about it. You're skinny. Just don't worry. Just eat butter, eat fat. Yeah. Eat whatever you want. Don't worry about it. But the problem is that they get more and more obese. So if you don't measure body fat, you just go with BMI, you miss this. Next slide, please. So what could we do? So the problem is with many of our patients who are overweight or obese, what are they told to do? Well, they're told to go on Ozempic. Everyone is well familiar with this, GLP-1 receptor agonist or the dual agonist with GIP. What is the challenge with these is that up to 30%, well, it depends, tirzepatide, closer to 40, Ozempic, 24. So it's around 30% of the loss of weight is skeletal muscle with these medicines. The problem is many of our patients get put on them, and then when they're on them, they lose muscle, they lose strength. Now, the drug companies say, well, don't worry about it. It doesn't matter if you lose muscle. Obviously, if you've got muscular dystrophy, it's a big issue. And as we get older, it's a big issue. So what do the drug companies do? The drug companies say, just eat lots of protein and do exercise, and you're fine. However, what we wanted to do was to see if we could use multi-ingredient supplements to perhaps have a favorable effect to increase muscle and decrease body fat. Is it possible? Bariatric surgery, you will lose muscle. Low-calorie diets, you will lose muscle. Ozempic, you will lose muscle. So the first thing, of course, they said just exercise. So of course, exercise is beneficial in aging. Mitochondrial disease is shown to be beneficial. We can increase fitness in FSH dystrophy and myotonic dystrophy. We're now doing strength training, and we think that that's going to work. And very small studies have shown improvements in Pompe disease. So it works for patients, it works for aging. But is there any impairment when you are overweight or obese that blunts your ability to respond to exercise? Next slide, please. So we looked at our multi-ingredient supplement approach, and we tried this to look at mitochondrial enhancement, because we know that with obesity and type 2 diabetes, there's mitochondrial impairment. So we asked the question, if we use our mitochondrial supplement, could we actually have a favorable effect on obesity? So we used the high-fat fed mouse model. So if we have high-fat fed mice, you can see that they gain weight significantly. The gold standard is exercise, which is here in purple. And what we did is all sorts of different combinations. We used some of the more common weight loss agents. We used our mitochondrial enhancer with and without creatine. And the best we could do was this blue line here, pretty close to exercise. Now, one of the concerns with antioxidants is that if you blunt the signaling, you might blunt the beneficial effects of exercise. And I wasn't willing to eventually sell something or promote something that would blunt the benefits of exercise, but in fact, it actually improved the exercise effects. So the combination was better than each individual one. Next slide. So what did we do with this? We actually showed that we could actually increase mitochondria in the white adipose tissue. So PGC1 alpha went up, and we used a variety of different metabolic enhancers, we called them. Health Canada said we couldn't call it that, so that's why we used this term TRIM7, which they allowed us to use instead of metabolic enhancer, although I think that's a little more descriptive. And you can see also increases in mitochondria as well. So these are the high-fat fed mice showing impairments, as others have shown in the white adipose tissue, and improvements with these supplements. But take-home point, it's always better if you add it with exercise. Next slide, please. Inflammation was down. Next slide, please. And the reason we went with what we called originally metabolic enhancer 3, we had 7 different combinations, was UCP1, uncoupling protein 1, was highest at the protein level. So this one here, which turned out to be our 7-ingredient supplement, was the one that we went forward with human clinical trials. Next slide, please. But before we did that, I had one of my colleagues saying, Mark, I don't believe it. There's no way. There's just no way with nutraceuticals you're going to have this beneficial effect. So one of my buddies, who's actually the Amgen chair in cardiovascular disease, Rick Austin, we gave him the stuff blinded. And this is what the fat pads look like on the high fat. And that was Rick's data when he used this multi-ingredient supplement to activate the mitochondria. Next slide, please. Rick's also a fatty liver guy, and so if you look here at the high-fat diet, you get a fatty liver, but that was almost back to that of exercise. So this is fat on oil red O, almost back to that of exercise with the supplement. And then finally, we did a human clinical trial. Yeah. So in our human clinical trial, we had 60 overweight men and women. We had 3 months of supplementation, and it was a real-world study. So we didn't bring them into the clinic and have a nutritionist call them every week. We just said, just like a family doctor, here's the Canadian guidelines for exercise. Here's some nutritional guidelines. We'll see you guys in 3 months. Unfortunately, what happened was something called COVID-19. So a lot of folks were very sedentary, and so you can see that people did gain weight because they switched from being fairly active to inactive. However, it was all randomized, double-blind, third-party, independently data locked, and you can see that those that took this multi-ingredient supplement lost more weight versus those on placebo. But importantly, we also had a 26% reduction in AST, which is a marker of fatty liver disease, which kind of fits with the earlier stuff from Rick. But importantly, it's now working. That's the back. There was no loss of muscle. So it was one of the few instances where by activating mitochondria, lowering oxidative stress, we could lose fat, but maintain muscle. So they're telling me my time's up, even though I started a little bit late, but we can always talk more at the break. I think they're trying to kick me off now. So I had a couple more slides, but I won't get into it now. Thanks so much.